Well, you've heard some great examples in terms of how these collaborators are using payment performance measurement and reporting. I heard this kind of approach described as speed dating. So we're going to do some speed dating now through payment reform. And I've been asked to talk about the example of the Puget Sound Health Alliance's payment reform pilot. By way of background, we're a purchaser-led multi-stakeholder coalition, and I credit Ron Sims, the then chief executive of King County, who went on to be deputy director of HUD, of going out and recruiting key employers and labor trusts like Boeing and NRHI and the state, the retail clerks, all the major health plans, all the major provider systems, the pharma, patient advocacy groups to come together to work on reducing the misuse, overuse, and underuse of healthcare services. We represent then about 2 million lives in Puget Sound, and we are just beginning to gather data on a statewide basis so we can expand our reporting efforts. About 3/4 of our budget comes from our members who pay dues of sorts, and 1/4 from grants, principally from the Robert Wood Johnson Foundation's Aligning Forces for Quality program. And we're also a part of the learning network that ARC has for chartered value exchanges. Like these other entities, we have multiple strategies to affect change. Our key strategy and fundamental work is in performance measurement and public reporting, where we report on the variation in quality and beginning to report on the variation in cost. And as an example, I would cite King County has used our report to change their benefit design with respect to generics as well as their premium contribution strategy, and the net result, they saved $20 million. So there are some very practical applications of this information. But I'm going to focus on medical home as a payment reform strategy. This started from a learning network that the Department of Health operated for medical groups to learn about medical home. And it netted then an introduction of legislation at the state level that would enable pilots of this nature that could be have the benefit of exemption from state antitrust and federal immunity from federal antitrust laws. It was a very important protection to allow this work to begin. So because of that, the Washington Purchasing Authority is really in the lead, but the Alliance was identified as the co-convener for the effort. And we had the benefit as well of an additional grant and technical assistance from the foundation. And so we started, as we would in many cases, with a multi-stakeholder group, with a group of purchasers, payers, medical groups, the Medical Society, the Hospital Association, the governor's office, to design this approach. So basically what our objectives were, we wanted to test a multi-payer payment model that would have a common method, a common measurement, common reporting. And what was different about this particular pilot is that in many medical home programs, they pay for structure. Do you have these capabilities? Or they pay for process. Do you do these things? In this instance, we're saying we're only paying for outcomes. We're going to pay for results. And that was an important distinction. So it created an accountability for the additional payment that would be received with both shared savings as well as shared losses. So both upside and downside risk. And what's important about the multi-payer approach is we want to be able to have enough patients to bring the critical mass of patients to the practices so that it would warrant the changes that they have to make in order to make a medical home really operational. And one of our objectives, of course, is make sure that we weren't compromising quality, that we maintain the same kind of quality results that we would expect along the way. So we launched this. There are 7 different payers. We have both some regional payers, some national payers, some managed Medicaid. We did not have Medicare fee-for-service or Medicaid fee-for-service. And in the design, I'll cite a couple of things. As I mentioned, it was still a fee-for-service approach, but we pay a care management fee, initially $2.50, declining to $2 per member per month, to help underwrite those investments to help support this approach. And as I mentioned, it's really focused on outcomes, reducing those preventable events, principally focusing on a 30% reduction in avoidable use of the ER. And the savings or losses are shared 50-50, so you can get 50% of the savings. But similarly, there could be in losses a reduction in the PMPM the subsequent year or a reconciliation at the end. And then using the Alliance's metrics for quality, making sure that there's no diminution in the quality metrics by virtue of this approach. So we're working with 8 different medical groups in 12 different locations. They have a variety of structures. You know, they come from different parts of the state. They are, you know, they're all primary care, but they have a varying in terms of size and their ownership and kind of their location. That's resulted in kind of having some variation in terms of the types of practices that are included. How we got to them was we were not prescriptive at the front end of what you had to do. We don't have a high prevalence of NCQA qualification for a medical home. And so we asked them to tell us what the plan was. They applied by kind of mapping out, this is how we're going to be successful in getting these results. And so we reviewed their applications and what their competencies were, their readiness, selected a subset, and then the plans gave us baseline data on what those attributed patients would be so they could take a look at what the performance is currently and then make a decision to commit. So it's too early to have any real results yet, but I think we have some successes to acknowledge. I mean, first of all, it launched. It took 18 months. It took longer than we expected, but we got to the starting line. And given how fiercely all these plans compete, it was really an accomplishment. And so in May in 2011, we started with these practices. We were successful in creating a common design with metrics and payment methods, this care management fee, a fee-for-service approach. Obviously, each plan has its own fee-for-service levels, but that had a common approach. And at this point, 21 months into this, we still have those same practices, those same plans, and so we feel good about being able to sustain the participation. With the practice, the patients really, there are about 27,000 patients who are in this model. They pretty much stabilized at that number. Obviously, there's some variation by medical group, and then similarly, the variation payment will vary. But we've been able to deliver, or the plans, I should say, have been able to deliver $1.2 million additional monies to these practices so they can invest in care management and the like. And the things that are working well is we've got a good system for attribution. These are largely, though not exclusively, PPO plans, so it's an attribution. It's not an enrolled model. And the practices are doing a number of things, as you would expect, in order to make this medical home model work. They've got registries. They've got care management nurses, coordinators. They're changing their scheduling approaches so they can have more same-day access. They're following up with their ED patients to have a teachable moment. So they're doing the kinds of things we would hope to make this work. Now, from the challenge standpoint, the principal challenge has been around data. And so it's the challenge of getting some consistency in approach. And we wanted to have a single approach to have one clear, consistent way to do things. But like with the design of the payment model, it takes time to work out that kind of agreement. And so frankly, in working with 7 different health plans, 7 different administrative approaches, that ultimately we had to compromise in order to get this off the ground. And the plans were reluctant to kind of just turn over a lot of data to us or to Milliman as the aggregator, and didn't want to minimize the amount of one-off work they had to do in order to make this operational. So we did agree that we could have a similar process, hoping that it would be, some consistency, but there would be variation acknowledged in how the data reporting would be completed, but hopefully using the same method. And so, as I mentioned, it gave us the go-ahead to proceed. It minimized the kind of changes that the plans had to make, and therefore should make it easier for them. But on the other side, on the other hand, it really has been inconsistent. And so it's made it hard as we're trying to determine the results to ensure that there's that kind of comparability you would expect. And it's really been burdensome for the practices. They're getting 7 different reports. They have to integrate it all. And so it doesn't provide the kind of clear signals that I think that really would be desirable for them. So in terms of some of the lessons that I would cite from the standpoint of the design, I think that having a neutral third-party convener has really been essential, not to just kind of pat ourselves too much. But, you know, there are a variety of stakeholders, as I mentioned, they're often competitors, and having that neutral source, I think, has been really helpful to allow us to kind of get beyond some of those differences. And having the health plan executives supportive at the most senior level is really important, not only at the onset, but on an ongoing basis, because there continue to be issues we have to work out. And we know health plans are going through a great deal of change for health reform, and trying to make this, continue to make this a priority is really important. I think we would be more insistent going forward about having a single agreed upon process for this contracting, the data calculation, and data sharing. I've cited some of the complications of not having that kind of uniformity, but that's really something that I think is important. And having a critical mass of patients so that the practices have enough patients that they can hire a nurse or they can make those changes, because it is not an insignificant commitment. From the practice standpoint, we really need to have medical groups that are ready to do this. As I mentioned, it requires a great deal of operational change and mindset and culture change. And so given the expectations we have of them, they need to be really prepared. Obviously, some of the groups that are capitated, that have been used to that, it's easier. But again, we need to bring along the others who really can perhaps develop this capability. And one of the other large challenges has been to get the connection between the providers, you know, the medical groups and the ERs. Particularly given the focus on managing avoidable ER, we've had trouble having that kind of regular communication, and even the hospital-sponsored, you know, medical practices have not necessarily been any more successful in getting those hospitals to work with them. And so trying to get that systemness between those two entities has really been a challenge. And yet the medical groups have been constrained. You know, frankly, the difficulty of getting information consistently, uniformly, on a timely basis has been a real challenge for them, and I think compromised perhaps their ability in the end to achieve the kind of results. That said, you know, I think particularly in, you know, primary care wants a sustainable model. I think they're very motivated, and they even, you know, despite these challenges, they're sticking with this, and I think they want to find something that will be sustainable for them. So my advice is, you know, we got to keep your eye on the prize, keeping that objective in the forefront, given all the things that are going on, trying to make this a priority, and using the leverage of and the opportunity of entities like regional health improvement collaboratives can be a real asset as we try to transform healthcare. Thanks.